GEMS was registered on the 1st of January 2005 with the purpose of ensuring adequate provision of quality healthcare coverage to public servants that is efficient, cost-effective, equitable, and provides further options for those who wish to purchase more extensive cover. We're currently South Africa's largest restricted medical scheme with over 800,000 principal members and 2 million beneficiaries. We offer 6 excellent healthcare benefit options, namely Tanzanite 1, Beryl, Ruby, Emerald Value, Emerald, and Onyx. Tanzanite 1 option is our entry-level network benefit option tailored for level 1 to 5 employees and is subject to network GP nomination and specialist referral rules. Beryl is also an entry-level network benefit option tailored for members with limited healthcare needs. The Ruby option is a mid-level benefit option tailored for members with limited to average healthcare needs. Ruby members also enjoy a personal medical savings account. Emerald is a high-level traditional option tailored for members with average to above average healthcare needs. The Emerald Value option is our efficiency discounted option of the Emerald option, tailored for members with average to above average healthcare needs. Onyx, which is our top-level benefit option, tailored for members with above average to extensive healthcare needs. Our goal is to provide public service employees and their families with quality healthcare services at the most affordable rates. The brilliance of GEMS is demonstrated in our efficiencies to improve the overall experience for each of our members. An average of 2.9 claims are processed per second, an average of 72 registered babies per day, and we admit 0.8 members per minute per day to the scheme. GEMS truly understands the South African family and its needs. Some of our members who have discovered the brilliance of GEMS also shared their sentiments. Join us and discover the brilliance of GEMS. GEMS is an authorized financial services provider.
Good afternoon, everyone, and thank you for taking the time to join us today. My name is Nontobe Gondlovu. I am the Provider Liaison Manager at the scheme, and we are delighted to welcome you to this very important session where we'll be focusing on operational concerns that are impacting the physiotherapy practices. So the session is an opportunity for open engagement. So we encourage everyone to please engage with the scheme and with openness and in a respectful manner. We are here for 2 hours of today. And if we look at the agenda, we've packaged it in a way that it will focus mostly on the questions that will come, as we are aware that there may be operational concerns that you may want to address. So we'll start with a welcome address by Mr. Ramohelo Detswane. We will then go into 2 very short presentations. One will be done by the managed care organization under Dr. Ziyanda, followed by our administrator, Chantal Mbuto, who will take us through some key insights as well as claim overview. And then we will then dedicate an hour for questions and answers. And then in terms of the flow, we'd like to encourage that you use the Q&A box to ask any questions that you have. You can start asking questions as the presentation is being shared. And then from 5 o'clock, that's when we will start taking hands. So we'll do it both ways. Please share any questions that you have on the Q&A box, but we will then also dedicate an hour where we are taking hands and we are taking questions. And then just from a housekeeping perspective, we are available on our socials as well, on Facebook, on X, as well as Instagram and LinkedIn. So you can share your thoughts with us there. But just to reiterate, for this particular session, please use the Q&A box to ask any of your questions. So moving on, colleagues, I will then like to introduce our senior manager, Mr. Ramohelo Ditswane. He is the senior manager, healthcare networks and provider relations. He is a seasoned healthcare professional with over 25 years of diverse experience, both in the public and private health care sectors. So he does have extensive expertise in managed care as well as medical scheme administration. He will then do our opening and welcome. Over to you, Mr. Ditswane.
Thank you, Nontobeko, and good afternoon, colleagues. Thank you so much for making yourself available to meet with us as GEMS. We are not alone. We are also accompanied in this session by our administrator, Metropolitan Health, as well as the managed care organization, MedScheme. So we really take this session very serious as the scheme, as we have over the past year or so been getting concerns and complaints from physiotherapists. And I also understand that earlier on in April, while I was on annual leave, there was a session that was held with, I think, around 50 physiotherapists to attend to some of the concerns that they needed the scheme to look into. Now, following that session, a decision was made within our division that we need to go on a national roadshow through webinars and engage with all our valued healthcare practitioners, as we really value the partnership that we have with yourselves, as well as the members that you are servicing. Why are we doing this? We are doing this because we are guided by one of our key strategic objectives that informs us on how we need to engage. We need to engage in an open and a transparent manner. We don't hide behind emails. We don't hide behind contact centers. And this afternoon, present you with that opportunity somehow to interact with us, as you may have some of you through emails, but now you'll be seeing us in person. And this is not the only opportunity that you have to engage with us, as we also engage through societies like SASP and all others that engage us on a regular basis. We do engage them to address strategic matters, which we do twice per year. And then we also engage them through what we call operational engagements, where we attend to the day-to-day matters. But that does not only end there. We also go out and have a healthcare summit where we engage with everyone in one room. We have started this year in Cape Town. We moved to Limpopo, and we'll be going to the Eastern Cape in August, and then we'll conclude the year in the Free State in September. So if you are coming from those provinces, look out for the invites, and please feel free to come and have a face-to-face encounter, because all of us on this side of the scheme will be there in person. Now, what is very critical for us and also for everyone in this meeting is to also understand the time that the scheme is going through, the challenges that we are going through, as well as yourselves. What is very key is the current pressures that the scheme is having in terms of the high utilizations and the claims that we are having. And for those of you who have been around for a while, you'll remember in 2016, the scheme found itself with its reserve ratio below the required statutory percentage. We were at that time just, I think, around 8%. And at the moment, we are still safe, but based on some of the high claims that we've been seeing across various disciplines, we are now forced to intervene as the scheme to ensure that we are compliant. And as a result, some of the managed care interventions that we are putting in place may cause some discomfort, but that is how we need to manage in this scenario. And we want to take you also on that journey with us so that we all work together towards sustainability as far as the scheme is concerned. I'm sure all of us in this meeting room, we all want GEMS to still be in existence in the next 5 to 10 years. I know that there are also debates on NHI, but it's not for this afternoon. But the most important thing is around how do we all work together to ensure that the scheme remains sustainable, the scheme remains to fulfill its mandate in ensuring that the public service employees have access to private healthcare. And that matter requires all of us to put our hands together. It's like a tripartite alliance. We need you as our healthcare providers. Our members need you, and everybody also needs us as the scheme in this alliance. So for this afternoon, we really want to share with you some of the challenges that we have, and also to hear from you what are the challenges that you have, so that we can, as a collective, work together to resolve some of these issues. I know that there are times where emotions will go high, but I want us to all remain cordial in these conversations, and let us also remain respectful. Let's raise concerns and challenges in a way that will make all of us to work together towards the resolution. So please feel free to engage us. As indicated by my colleague, there is a chat functionality where you can post your concerns and comments there. Now, of importance also to mention is that from the 1st of July, GEMS will be rolling out a provider liaison office function to also cover the physiotherapy discipline. What this means is these colleagues will be now the face of GEMS in some of your practices. They will be coming to engage with you, attend to some of the concerns that you have. So this is what we are going to be doing in all the 9 provinces. Please, when they come, welcome them, allow them, and let's engage. They are not there to spy, they are not there to audit you, but they are there to build a relationship so that should you have any challenges, you know that face, you know that person that you need to speak to. We do admit that there are challenges with call centers and emails, but now this is an offering that the scheme is extending to ensure that our healthcare providers are well serviced across all the platforms. So with that being said, I just want to welcome everyone, and I'm looking forward to robust discussions in this afternoon. And I'm hoping that at the end of this session, we'll all shake hands and we'll all be in agreement. And I know that in certain instances, we will not agree, but I always say to healthcare providers, so is the nature of life, that we don't necessarily have to agree on everything, but we still need to work together. Thank you, Ms. Ndlovu. That's my address for this afternoon. Thank you.
Thank you very much, Mr. Detswane, for that very warm address. We do appreciate it. I do see that the Q&A box has already started being busy, and I just want to assure the colleagues that their questions will be answered. Some of them I see they're around authorization processes, and it will be covered in the presentation as well. So our first speaker for the day is Dr. Ziyanda, who is the Senior Manager, Provider Network Relations and Contracting in the GEMS Fund Management in the Med Scheme side. She is a pediatric specialist, and her professional foundation integrates specialist pediatric training with extensive program experience across HIV, PMTCT, in MNCWN, and other broader healthcare systems. Over to you, Dr. Ziyanda.
Thank you so much, Nondo. Good afternoon, colleagues, and thank you again for joining the GEMS Physiotherapy webinar. So as mentioned by Billy just now, the purpose of the session is for us to share our managed care perspective and also have an open platform for us to discuss. So as I start, we will then go through the presentation on my end, and I will share from my side. Okay. All right. So our first slide is looking at the context of why we are meeting today. And what we wanted to share with that is that from a scheme perspective, physiotherapists, we've noticed like a rise in expenditure, and mostly inpatient. And alongside that, we're seeing the variation in utilization, as well as billing and some, diagnosis coding. And I think that combination, together with what Billy had already said in the interim, we then need to have closer alignment and interactions with our providers so that we can better understand some of the provider trends that we are seeing. Next slide, please. All right. So, so the purpose of this webinar is therefore intended as a structured engagement, and it aims to for us to openly discuss and strengthen an alignment, where we look at the utilization, we look at the gaps, and then we can together look at solutions. And we work, as we can see there, as a collaborative effort. And the main agenda, or the main aim, is for us to be able to have a sustainable healthcare system and sustainable scheme as well. And the main objective is that we don't want to reduce necessary care, but we want to ensure that the care that our members need is delivered in a clinically and evidence-based way, and that is coordinated and sustainable and can align to best practices. Next slide, please. And then we will look directly at our trends. If you see in the first slide there, once it comes on, don't know if I've got a delay on my end. All right. So the key message from this slide is that we see in the first graph on your left, there's utilization in terms of number of sessions in orange and number of authorization requested. We can see that the sessions and the authorizations have increased over the years, over the 3-year period, and the increase is about for authorization, about 15% over the 3 years, and for total sessions is 18%, whereas the membership growth has not really been growing as much if you look at the bars on the left. So the year-on-year growth in utilization is outside of the membership growth, or out of keeping with the membership growth. The average session per auth are almost stable between 5 and 6 over the last 3 years. So that does show towards increased in number of authorization or overall authorization utilization use with physios. Next slide, please. And then the slide is showing about physios that do interact with GEMS members. And we see on the slide, on the graph on the left, from 2023 to 2025, we've had a dip in 2024 and then a rise again in 2025 in terms of the physiotherapists linked to GEMS members. And the growth there is also out of keeping to what we saw in terms of the utilization. So it's not even due to the growth in number of professionals that are accessing GEMS members. And when we break it down provincially, which you'll see there on the right-hand side, we also see concentration in the higher metros, Gauteng, KZN, and Western Cape. But if we look compare the 2 years, 2024, 2025, we do see that there is some growth in number of physiotherapists in the provinces, which is good for member access. But that also means that we then need to track the governance and align there that we are clinically appropriate in terms of implementation there. Next slide, please. Right. This slide shows the utilization, and on the left graph, you have 2024 compared to 2025 in terms of sessions in the bars, and then in terms of average number of sessions in the lines. We can see that the average number of sessions, if you compare 2025 in orange and 2024 in orange, there's been a slight increase in the number of sessions over the last 2 years, and the main provinces are still, there's larger provinces with more professionals as well as more members for GEMS. And then we can see on the annual growth trend that the growth is also, if you look at 2024, 2025, 2025 in regards to other sessions as well as authorization is higher. So there is a continuous trend. So this points towards not just a once-off change, but a continuous trend of increased utilization across the provinces as well as across throughout the year, except for in December month where we see a drop there. Next slide, please. Right. So this slide is looking at utilization per 1,000 life to try and standardize, utilization versus the number of people or members in that province. As we can see, the usual provinces, Gauteng and KZN, have high utilization together with Western Cape. But what emerges here is that we do see that Free State, which is low member base, low number of physiotherapists there, but we see quite high utilization there, and it's something that we need to look closely into, because then is it a matter of it's clinically relevant services, then that is fine, or is it a matter of there is some utilization pressure there that needs to be identified and appropriately managed. Next slide, please. All right. The analysis in this slide focuses on the top 20 physiotherapists over the last 3 years that show the highest volume in terms of utilization. And this is limited to a small proportion of providers. And we can see there's a provincial split as well, where it is mostly KwaZulu-Natal and Gauteng that has the highest utilization. And if you look at the average sessions, there's those top providers, quite high utilization there. And I think from a scheme perspective is whether, these are appropriate services. Do we need to review the length of treatment and any clinical appropriateness there, so that we make sure that we align to what is evidence-based in terms of care and what is clinically appropriate. Next slide, please. All right. This is my last slide on the utilization. And here we looked at 2024, where we had a higher utilization compared to the other 2 years that we had reviewed. And we looked at the top 10 providers. Here we looked at the overall number of sessions that year and split them in terms of average per month and then average per work day. And this is only for GEMS data. So, for example, the first provider would be seeing 36 sessions of GEMS members per work day. And I think here is where we're asking about a discussion platform about plausibility in terms of the frequency and utilization intensity. As we know, we've got a working day, and yes, maybe this weekend work, but is this plausible that this could happen, or is the utilization intensity that needs to be focused on? And some of the managed care interventions that it will be dealing with now are speaking towards trying to get that information and that validation, so that we are able to make sure that the services that are requested are needed by patients and are clinically appropriate, and they are valid. So I'm going to pause on this, and then I'll hand over to Itu to go through the managed care processes, and then I'll take on after her just to close. Thank you.
For that, Dr. Ziyanda. I will then introduce Ms. Itumeleng Sidiba, who is the fund manager. She is a healthcare fund manager with over a decade of experience in managed care, specializing in healthcare funding benefits and sustainable healthcare solutions. Itu, please go ahead.
Thanks, Nonto. Good afternoon, everyone. So I'll be taking you through the managed care processes. And as Billy mentioned earlier, we did have a meeting earlier on in April with some physios. We saw that it is prudent for us to actually give everyone an update as to what's been happening. If you can just move to the next slide, please. So it's very important for us to understand the actual journey in order for you to understand everything that's been happening. So if you have been in this industry long, you would know that before 2016, we used to have a process where providers could actually claim against the hospital authorization. And due to high cost claims that we actually started seeing, we actually put an authorization process in place where our physios as well as other allies would be required to actually load an authorization separately. So that started off in 2016. So there are two ways for you to get an authorization. So in 2016, it was three. It was through UMS, the hospital authorization email address, and then you could also call. In 2025, the call center option or functionality was then removed because we are moving towards a more digital self-service team, and that was put in place from 2025. And we started seeing that a lot of providers became increasingly frustrated because they had no access to the call center, and they did not necessarily know how to utilize our UMS platform. So as a team, we started actually hosting your training sessions so that providers are able to utilize UMS. And then also, beginning of this year, we actually started increasing high call volumes, high queries in the back office. So what we started seeing is that as much as we had closed the option for the physios to call, we actually opened it up for that period because we knew at that point that there are high call volumes in the call center, but also there's quite a big backlog. So this backlog was between January and around March, and we did follow certain processes to notify relevant stakeholders. But also, what we started seeing is that then there was also a mismatch between the actual authorization that was granted or the letter that was granted as well as the claims. And I think that's what really caused a lot of frustration. And that's what I will then be going into now. So then the last process that was implemented, then you can move to the next slide, Jay, was the actual implementation of additional information or additional clinical information for that matter. So I'm going to go straight into the issues that we identified this year because I think this would actually help a lot of us around the room, and it will help you a lot as providers, and this will help solve both your 2025 issues as well as the 2026 issues that you may have experienced. So in the meeting that we actually had, it was noted that we had high rejection reasons, even though the authorization was actually released. Upon investigation, we actually noted that our authorization letter was pulling through the hospital length of stay and not the number of visits that were actually authorized. So how visits actually is that for each time the patient goes or is seen in hospital, we load a visit on our side. And generally what would then happen is that the initial letter will I'll give an example, letter of 8 days length of stay. The letter, that's what the letter was actually reflecting. But when you look at it on our side, it would have only approved one visit. So then what would then happen is that when you try to claim as a provider, it will approve the one and pay you for the one, but it will reject for the rest as no authorization. So the normal standard process for authorizations, even before this issue, is that you load the authorization, you submit a request for updates, and you would put all your notes in UMS. If it's via email, you would put all the content in the email body so we know which dates we actually need to approve for. And so as part of this started actually causing a misunderstanding between what was approved and what was actually authorized. So what would then happen is that due to this, I think a lot of providers became increasingly frustrated, which is understandable. So what we then did is post the meeting, the team has actually gone and they have identified and fixed the actual auth letter, but also more than anything, We have also started accepting spreadsheets for the period service date, January to April 2026, and you will see that under important to note on 6. So that means any authorizations where you would require more than one visit and it was not updated, that means you are required to do a consolidated spreadsheet and submit it to the team so that they can look at it. So this does not also mean that it will be an automatic approval. It just simply means that the team will have an opportunity for them to look at your practice information in a consolidated view and actually make funding decisions on each case. If you can go back, Jay. So it's important for you to actually take note when you load an authorization on UMS as to the information that you receive in your letter or the information that's on the system. And therefore, you take next steps, being you need to put in your notes actually the dates that you require an authorization for. And I've just put the date format at the bottom as to the one that the system would accept in the notes, and that would actually make it simple. So if, for example, it's the 10th of June up until the 15th, so it would be date, month, year, the 10th, and then you do the same for the 11th, you do the 12th. So you don't do dash till the 15th. No, you need to actually put each of the dates because that's how the system would actually load the different authorization numbers. And also, I think as a standard, one thing that we encourage providers to actually have a look at is to check the number of days that are approved. So it is important for you to also just take note of your auth letter and have a look exactly what has been approved. So before Jay moves to the next slide, please take note. It is date, month, and year. On the next slide, we really just cover some of the questions and concerns where we have been getting a lot of rejections, and I thought it is important for us to really just talk about it upfront. And I know that I'll give an example for your laparoscopic procedures. If you look there, it says we would decline the request for laparoscopic procedures. For physiotherapy for laparoscopic procedures. And in this instance, as a provider, you are allowed to appeal the decision, and you would then need to submit a motivation from the treating provider in order for us to actually understand the actual clinical information. I know in the meeting that we had in April, there was a lot of discomfort around this. So this is currently our clinical protocol. So this information shared on this particular slide is based on our current clinical protocol. And I'm not saying this is never going to be reviewed. What I always say is, as providers come together, send your proposals and your research to our health policy unit. They are willing to hear, they are willing to engage on certain policies, but this is the current policy that we have. I think another one that is always an area of concern is in your mental health admissions, where we actually decline authorizations for your dysalgia, your muscle spasms, your group relaxation. And the only time we would actually consider it is if there was, for example, a recent medical or surgical admission. And other than that, we would actually need more clinical information for us to make a funding decision. I think earlier on, I saw one of the notes or one of the questions around certain questions that our staff will ask from a clinical perspective. I think we take it for granted. And also, maybe just to mention, I've been speaking to a lot of providers over the last 2 to 3 weeks. And one thing that I always say, don't take it for granted that the hospital has given us the clinical information. Sometimes they have given us the bare minimum for us to make a funding decision on their authorization. They have not necessarily given us enough information to actually make a decision for your particular case. So I'll give an example. If you go to the next slide, Jay, I'll give an example. Let's say a patient is admitted with a foot let's say, needed an arthroplasty and they needed to mobilize, it makes sense for them to have, physio. While they're in hospital, then the patient to have pneumonia requires chest physio in that instance. So the expectation from us would be you need to actually tell us the reason why you are actually doing the actual physio itself. Don't assume the hospital has told us, because by the time we get that information at times, this is instances where the team will say to you, but it was not warranted in that instance, because it could be that it's a mismatch of information. So I always say it's important for you to give us as much information as possible in order for us to make that funding decision. So on this slide, I really just talk about our UMS system and why it's important to utilize our UMS system. And just from if you go to number 23J, the UMS slide really tells you about the importance of using our UMS system. So UMS is our internal system where you are able to load an authorization, and it really just allows you to get that reference number up front. So with the reference number, you would be able to then query or attach additional clinical information. So as a way of example, if the authorization is pended and we require additional information, you can go back in and you can make your notes. It's as simple as that. So you don't actually have to send an additional email, and you're also able to track your visits, how many visits we have actually approved versus what you have requested. So it's quite a nice tool to have for you to actually constantly track what has been approved versus what you requested. And it's always nice because when we engage with providers, and Billy also mentioned it earlier, we don't try to hide behind emails. We do engage with providers. We are open to listening as to the challenges that you have. If you have submitted the information and you are still not getting the joy, there is also a process that I will touch on in the next slide. So that last bit there on this slide speaks to if you require UMS access. So there is a process where you can actually register to have access to UMS. But if you need training, you can email that MCO PRS queries email address, and the team will organize that training and share all the information needed to do the actual training itself. If you go to the next slide, it really touches on the escalation process. And I want us just to pause on this particular slide. If you can bear with it. Colleagues, I just needed to snuffle. So this particular slide is the actual escalation process for our hospital auths department. So our hospital auths email address is equivalent to utilizing UMS. And if you then don't get an answer within 8 hours, there is the escalation email address, which goes to the team leaders. Then there's the manager's email address. And then lastly, the senior manager's email address. Now, if you have tried all this and you are still not getting assistance, our fund management department, which is under Dr. Zianda, Bongi, and team, will actually go in and assist you on that MCO PRS email address. So if you do have that email trail that you have followed all the steps and you're not getting assistance, they are there to actually intervene and make sure that you get the help that you need. If you go to the next slide. So before I hand over to Dr. Zianda, I would just like to just mention and reiterate again, in instances where you have experienced concerns and queries for claims before April, please utilize that MCO PRS queries email address, preferably in a spreadsheet. And this is really in instances where there was no authorization. This is not for claims queries. it is open. For now, the team would be actually there to assist you to ensure that all those accounts, we can actually come back to you and actually go through the next steps with you. We have been engaging with various providers, and some have already started submitting their spreadsheets there. And that process is working quite seamlessly. But as at now, the normal process, so if the date of service is after April, you would utilize the normal pre-authorization process, which means you would email hospital auths at gems.gov.za, or you would utilize UMS, and you would follow the escalation process if you're not getting any assistance. So that's the process for current. And then for the old cases, please can you then email that PRS email address. Thanks, Dr. Z. Back to you.
Thank you, Itu. I was finishing off a question. Next slide, please. All right. So this slide is more speaking to when we have some of these engagements and we're speaking about submission of letters of motivation and clinical information. Then we get asked, is it that the providers are not breaching confidentiality? And this is just to reassure providers that this is not a breach of confidentiality, as members are registered in the scheme, and it is shared confidentiality as described in those regulatory bodies that you see there. And I think the flow is more for understanding, so that the provider submits the clinical information so the scheme can assess the request, and whether it be the claim or an authorization request, make the necessary review for medical necessity and benefit, and as well as scheme rules, and then it gets funded appropriately. It matters because the information is needed to manage the cost escalation, the high utilization that we are seeing, as well as over servicing and high intensity. And at the core of it all in what we do as GEMS is to make sure that the member is protected and we still have a scheme that is sustainable going forward. Next slide, please. And I think to end off, I would like to then just share that, as much as we are seeing the utilization pressures, and we need to then better understand from providers, what's driving some of these outlier volumes. We know that there could be increasing, need for services, but some that go beyond the standard or the norm, where we're seeing high average hours per workday per provider who's registered as a solo provider. How do we then, work together to manage that? And the provider level implication is also there, so that we know that the treatment that is rendered is what is needed by the patient. And as managed care, we are looking at ways of making sure that the process is not impeding on your services, but also making sure that the scheme is sustainable. So that's why there's managed care enhancement. In terms of operation, we touched on UMS that we can use to make the process a bit quicker than calling. And I think what we want out of this is to have a shared way forward. And overall, we want to make sure that we are aligning our clinical governance, that we still need to be operational, and we still need to have shared accountability so that we can have sustainability for the services we render. Thank you so much. I'll hand back over to you, Chair.
Thank you very much, Dr. Ziyanda and Udu, for that insightful presentation. I am seeing that the questions are being answered in the chat. There is some way we are requesting examples to be shared. We will put the email addresses where you can share those examples in the chat. Please notice that the email addresses will be for the purposes of the session and to share those examples. It's not taking away from normal processes. So moving right along, I would like to then introduce Ms. Chantal Mboto, who is the head of claims operations at Metropolitan Health since 2019. She holds a national diploma in nursing science as well as public administration, and she has completed a senior leadership program in Duke University. Chantal, over to you.
Good afternoon, colleagues. Thank you, Nonto. So in today's session, I will be focusing on physiotherapy claims trends, utilization patterns, cost drivers, We'll review rejection insights and also share some insights and findings from a fraud, waste, and abuse perspective. The objective for today's session, from a claims administration perspective, is to provide transparency on current utilization trends, to highlight any areas of concern that we see in the claims data, but also to discuss opportunities for improved billing practices and to ensure that we're able to enhance our member and provider experience. So this slide, and if we start with the table on the top left, it is the total physiotherapy benefits that we have paid year on year. And what you'll see from the trend on this graph is that the benefit spend has increased significantly over the last 4 years. If we look at 2022, where we paid 613 million, to nearly 947 million paid in the 2025 benefit year, and you can see that is quite a significant increase. This does represent substantial growth, which is driven by increasing utilization as well as treatment intensity. These trends do highlight the growing importance of physiotherapy in supporting patients in rehabilitation, but also for the treatment of ongoing chronic ailments and conditions. If we reflect on the map to the top right, this is the percentage visits across provinces, and what we note is that Gauteng is the leading province with 25% of visits attributed to Gauteng province, followed by 24% in KZN and 10% in the Western Cape and Eastern Cape respectively. The graph to the bottom right is a GEMS profile in patients, and this is just giving a view of the demographic of our female and male population that are accessing the services of physiotherapists. And what we do see in the female population, we do note that the majority of our patients between the ages of about 60 to 70 years of age do tend to seek services of physiotherapists, and that is averaging at about 15% of patients in those age groups or of members in those age groups are accessing the services, while if you look at our male population, significantly lower, but of course also peaking around a similar age, 60 to 70, but lower utilization at about 6%. And then just in wrapping up this slide, the percentage benefits during admission, so 56%, so about half almost of that 947 million paid to the discipline is for services obtained in the in-hospital setting, with about, the balance of that 44% of benefit spend attributed to out of hospital. So year on year, we see an increase in the benefit paid. It's up by 11% if we compare 2024 to 2025, and about 16% in a 2-year period. If we move on to the next slide, this is just a bit of more detail highlighting the actual percentages that were reflected on the previous slide. So the total benefit year on year, 11.5% increase noted, and a 15.8% increase noted over a 2-year period. I think we are cognizant that we have noted an increase in the number of families and lives on GEMS, because we do continue to see positive membership growth. However, aligned to that, the average benefit per life has increased quite significantly by 7.2% year on year. And then by 10.4% over a 2-year period. And cost per patient has also increased by about 4.5%. You can see there also with the 5.8% increase over a 2-year period. What we also monitor is the total number of claiming practices, and this continues to increase year on year. You can see for claiming practices in 2025, we've seen claims from 3,262 practices. We also monitor first-time claiming practices, and this doesn't mean that these are new entrants into the market, but that they've started claiming from GEMS for the first time in the particular benefit year. And you can see that is sitting at 263. And then if we just look at the top 10 claiming practices, they attribute to, on average, about 60% of their total spend is paid to the top 10% of practices. Our next slide is just a focus on the rejections that we see in the claims data. And as much as, we pay a significant value in physiotherapy claims, we're also quite concerned by the high rejection values that we see, because ultimately we would like to ensure that we pay claims correctly, the first time to reduce the admin burden. But what we see in the rejections, that the total value of rejections, if we look at the January to December 2025 experience, we're sitting at over 62 million. And of that, the top 5 rejections contribute to 67% of the spend and 58% in terms of the number of claims that are rejected. And if we just reflect on the top 5 rejection messages, we note that pre-auth required is the top rejection that we see in the claims data. So almost half, or about half, 50% of the total rejections is due to pre-authorization required. And we note that there are and have been concerns around the authorization and approval process. However, where claims are submitted and the authorization is either not yet approved or the authorization has not been updated, claims would generally reject with pre-authorization required. And once the authorization is then approved, the claims are processed and paid. So this does reduce, but it is one of the top, or is the top rejection that we see reflected in the claims data. And then we also see physio treatment session duplicated. And this is as a result largely of AM and PM sessions where the times of the sessions are not provided. There is a requirement on submission of AM and PM procedures to include the actual times of the treatment to be able to facilitate payment. And we do also see quite a significant amount of rework and reprocessing of claims as a result. However, if you compare to the top rejection, it is significantly lower, but still of concern at 3.2 million. STEL claims, we do note 2.6 million rand worth of STEL claims for the period. However, if an authorization has been requested and is updated or approved at a later stage, then there is an opportunity to review claims for processing. However, it is important to note that claims should be submitted within the 4-month period after the service has been provided. And then if you need to follow, a request for authorization or update of the auth, at least the claim is on system and can be reviewed retrospectively. Maximum number of physio treatments exceeded. We often see this. We do look to the authorization to determine what has been approved, how many sessions have been approved before the claims are paid. And if there is misalignment, then the claims will generally reject with this error message. Once the authorization is updated, then the claims can be subsequently reprocessed, or if additional information is required in the form of a motivation, that is then subsequently reviewed by the medical advisor. And then lastly, scheme exclusion. We do note the number of claims significantly lower than, the top 4, but it is contributing to about 1.5 million rand worth of rejections seen in 2025. If we move on to the next slide, this is a view of the top ICD-10 codes in terms of the benefit paid year on year. Here we've compared a 3-year, or brought in a 3-year view of claims for the top 10 ICD-10 codes and tariffs. And really, the slide does highlight the primary clinical conditions and tariff codes that are driving physiotherapy expenditure. What we see from an ICD-10 code perspective is the Z50.1 for other physical therapy does remain the highest billed or claimed ICD-10 code, and we do note an increase in this in the expenditure of 19% in 2025 when you compare to 2024 experience. And you can see across the top sort of 6 or 7 drivers of ICD-10 codes, lower back pain featuring the amongst the top 5. And those have increased quite significantly in the 2025 benefit year by over 20%. If we reflect on the tariff codes, we do note the 501 is the highest driver, and that has been, the trend year on year. And it is, as a result of the services that the physiotherapists provide, that has increased by about 11%. And if we look at, all of the top 10 tariff codes, we do note an increase seen in the 2025 benefit year, some not as significant as others. And we do also note that the scheme does have a chronic back and neck program, and we do see that those claims also, featuring there in the top 10 for the discipline. If we move to the next slide, it is a very similar view and picture. We'll just wait a little bit as what I've presented on the prior slides. But here what we've brought in is the Jan to April experience year on year and comparing that trend. And what we can see to date, if we just reflect on the 2026 experience, the benefit paid is slightly below the 2025 benefit year, but we are mindful of the physiotherapy process changes that occurred, and the fact that authorizations are still being approved and claims are still to be paid for the period. So we expect to see an increase in this value going forward. But as it stands currently, we are tracking 8% lower than the benefit that was paid for the same period last year. If we reflect perhaps just on the prior benefit years, we do expect to see an increase over time, and we continue to monitor, the trends. However, the decrease may reflect, change in utilization patterns. Also, given that from time to time we may implement changes to billing rules, but it could also be provider behavior changes, but it could also be as a result of benefit management interventions that have been implemented. The rest of the slide is pretty similar to what was presented earlier. And if we reflect on the next slide, it is a very similar picture, but giving the 2026 January to April experience from a rejections perspective. So it is no different. I think if we look at the top sort of rejections that we see in the claims data, but what we also note, perhaps valid proof of payment required is featuring there as number 5 in 2026. Generally, this would apply if the member has paid upfront and is claiming back from the scheme, but it's not really as significant as the top drivers. And we can see that into 2026, pre-auth required does still remain a rejection, where we're seeing significant value at almost 16 million of the total 25 million is attributed to this particular rejection. But as indicated, once the authorizations have been approved, then the claims are subsequently reprocessed. If we move to the next slide, it is really not very much different in terms of the top drivers from an ICD-10 and a tariff perspective, and perhaps it's clear on this slide where you see the reduction in the year-on-year claims experience. So you can see in the top 10 ICD-10 codes, the Z50.1, in 2026, we are tracking 9% lower than the 2025 claims experience. And I think the second one is the cervicalgia ICD-10 code, the M54.22, which is tracking 4% less than the previous benefit year. But as I indicated, we still expect to receive claims for this run-off period, and it is subject to change. And more significant, I think, in terms of the reduction in the year-on-year claims experience is seen on the tariff codes, and it is really very consistent across all or most of the top 10 tariff codes, of course, with the introduction of the chronic back and neck that we see there that has increased in 2026. If we move to the next slide, the next few slides really highlight a few fraud, waste, and abuse insights. And these are relating to investigations that, have taken place within a unit called claims risk, where we do identify any areas of concern within, and it applies across various disciplines, but these insights are specific to the physiotherapy billing practices. On this particular slide, we have brought through two primary concerns that have emerged. The first one being the utilization or the use of tariff code 72501 for rehabilitation. And we know that this is the highest paid code for physiotherapy practices. And on average, it does form about 20% of practice revenue. What we see that there does appear to be incentive to add to as many treatment sessions as can be justified, and many practices charge the code routinely for all sessions, where there's no clear criteria for the use of 501, which has been disseminated to all practitioners. During audits, when they are requested to provide, things like clinical notes, there's really no distinction made as to the specific treatment that relates to this particular code. There's no duration of treatments that are recorded to validate the additional time that is also being billed. And what the recommendation is, or suggestion is, that there could possibly be a guideline on the use to curb the abuse, or to reduce the reliance on practice audits on this particular tariff code. And the second matter is disputed services, where from time to time we do receive members that report being billed for services that they have not received. And the causes range from administrative errors, once they are investigated, to potentially fraudulent activity, but it does take considerable amount of time to investigate. And such complaints really, either do create administrative burdens, or may trigger unnecessary or unwarranted audits for the practitioner. And I think for this particular concern, we really are requesting that, there is improved billing practices, that documentation standards are maintained, and, member communication and education can also significantly reduce these errors. Part of the findings when investigations are done is that we can see that where there is the use of locums, that members also understand who they're being treated by, because a claim may come with the billing, sort of practice details, but the member was treated by a locum as an example, but when they see the claim, they don't make the correlation or the connection, and that sometimes then, creates some of these audits that we then need to investigate. If we move to the next slide, I'll try and wrap up in the interest of time as it is already 5 o'clock and I'm cutting into the Q&A. But this really is a case study that demonstrates, the data analytics capability to identify potentially fraudulent behavior. And if you look, albeit maybe small, there's a red dot that you'd be able to see in the concentrated area. Where a provider was identified due to a sudden increase in benefits paid and higher than expected treatment costs. There was also member disputes or complaints regarding the services not being rendered. And so a review was done on this particular provider, and the findings really identified that there was excessive use of the rehabilitation code, the 501, unusual geographical treatment patterns that were seen for this particular provider. So as much as they are concentrated in one area, you would find claims being received for members or patients in various areas within the province or even the country, across provinces. We also see multiple member disputes, time-based billing anomalies, and following, the full investigation, this provider was referred to HPCSA for further investigation, and the provider, there was a value identified and equated to the anomalous behavior that was in the range of 155,000. If we then move to the next slide, this is another case study. And this does demonstrate a different type of billing concern that has been identified due to a sudden increase that we saw in the provider claiming pattern. And you can see on the graph to the right, there was a peak that we noted, and then it sort of plateaued, and then we note in the last part of that particular graph, a significant or rapid growth in claims that was seen. Frequent use of multiple modalities were billed, and the billing patterns are compared to peer benchmarks, and these were exceeded by the practice or the practitioner. On investigation, the provider indicated that limited formal billing education is what contributed to the issue. And the investigation did conclude that the behavior appeared more consistent with inadequate billing knowledge than deliberate fraud. Education was recommended to the provider. And I think as we identify these irregularities, we also try to educate providers on the societies, associations, regulatory bodies that are available to them to support them, with the challenges that we see in the incorrect billing. And we do then continue to apply ongoing monitoring to assess if the behavior does correct or continue. And then my very last, fraud, waste, and abuse trend is this one is a case study that was done. And it was a HPCSA study that was done in 2024. And this slide just summarizes the findings of that study that was done to examine physiotherapy transgressions between the period of 2010 to 2020. And the key findings really are that 21 transgressions were recorded over that period. And the most common offences involved billing and claim-related misconduct. And examples included charging for services that were not rendered, inaccurate invoicing, false claims submitted to medical schemes. Additional transgressions involved failure to obtain informed consent from patients, over-servicing canvassing, misleading advertising, professional conduct violations. And these findings really reinforce the importance of ethical practice, of accurate billing, and professional accountability. So these were just some of the fraud, waste, abuse, and now we're introducing error insights that we thought important to share with the physiotherapy practitioners today. And so that does bring me to the end of my presentation, and we do appreciate the important role that physiotherapists play, I think, in improving the health outcomes of our GEMS members. And so we are looking to collaborate and also learn from you on what we can do better in terms of what we share with you and also the services that we offer. Thank you, Chair.
Thank you so much, Chantal, for those insights. Colleagues, I would like to now open the floor up for questions in the form of hands. So if there's any colleagues who want to just raise your hand, it's under the reaction button. You can just raise your hand from there, and then I will take the questions. I do see that there are 3 hands up already. I will start with Teresa Ashdown. If you can unmute yourself and please ask your question. You did unmute and then you went back to mute, Teresa. If you can unmute and ask your question. Okay, we'll come back to Teresa. Let's move to Joyful Msomi. If you can unmute.
Hi, can you hear me?
Yes, I can.
Hi, thank you so much, guys, for engaging us and giving us this presentation. I've got 2 questions, and the other one is just a clarity. I'm just going to start with the last speaker, Chantal, that spoke about the over-servicing of the 501. I'm not sure, guys. I don't know if I understand her correctly. I understand the fraudulent part. I understand the misuse, but I'm not sure if the medical aid understand that the tariff codes are actually the treatment that we render. So if somebody says you are over rendering, what does that mean? In terms, because if I'm treating you as a practitioner, I'm the one that says, I'm going to give you this treatment because maybe it's the best treatment you need to say. So if somebody says you are over servicing, what does that mean? Maybe I didn't get that. That's my first question for Chantal. Number 2, I have an issue with the typos or the dates, the fraudulent. I know I have been queried. You know, this is a typing error. Sometimes you type in an incorrect date. It doesn't mean that it was fraudulent. Is it possible for you guys to engage us when this happens? To say here it's been disputed, then look, then I can come back and say, no, it was a typing, because claims are typed by individuals sometimes. So it's not, it mustn't go automatically to fraudulent, but to engagement. Engage us so that we can tell you what's going on. That's number 2. Number 3, this is the last one. It's a comment. Even Dr. Zianda as well as Itumeleng Sidibe kept on referring to the word allied. Guys, we are not allied. We are under HPCSA. We are not allied individuals. We are actually part of the HPCSA. We are rehabilitation professionals. Allied individuals or professionals are your chiropractors, are your or homeopaths. So I think, I'm not sure because if you don't know what we are, it is very I'm not sure how to say this. Maybe when we are looking at our claims and what we do, it is easier for us to misinterpret on what we do because you are not sure on what we are. We are rehabilitation professionals. We are not allied professionals. We do have an HPCSA, and we're under the HPCSA, not the AHPCSA, which is the allied HPCSA. Those 3 for me, I think if you can answer them, I'll be perfectly okay. Thank you so much.
Thank you, Joyful, and your comment around the allied is noted. I will hand to Chantal to answer the questions that you had. Thanks.
Thank you. So just to start with the 501 joyful, and when we speak to overservicing, I think if we just take a step back and consider the sheer volume of claims that GEMS receives on a daily, monthly basis and on an annual basis, and the volume and value of claims that we pay on an annual basis. So if we look at last year, we paid almost 67 billion rand worth of claims, and we do try as far as possible to automate, claims rules, and it's not always possible to identify upfront things like overservicing. It's not always easy to identify upfront, even typing errors or input errors, quantity errors, limit errors. And it's only retrospectively when we're doing the reviews are we then able to identify and pick up things like overservicing when we speak to overservicing. So what typically is done, reviews are done after the fact. And, practitioners, and it's not only in the physiotherapy discipline, it's across the various disciplines. Practitioners are compared or benchmarked to their peers in a similar setting, providing similar services. And where we do identify, peers that are above what the expected benchmarks would be, that then warrants an engagement with the provider. So you'll find from a claims risk perspective, they may request additional information to qualify the increases that we are seeing in the billing patterns. So when we say over-servicing, generally, it is once we've done a bit of an investigation and we've engaged and we're able to determine that providers, based on the feedback that we get, they would indicate. A lot of providers use billing bureaus and agencies to submit claims, and a lot of the time when we engage with them, they will indicate, but my billing bureau is the one that submits claims on my behalf. And you'll see in terms of the use of 501, it is billed on every single claim regardless of the treatments that is being provided. And I think here, in us sharing the insight, is just to say that we do note in certain instances that this is higher for certain physiotherapy practices. And when it is higher, we're just trying to understand the clinical need versus what we sometimes refer to as template billing. In terms of the typing error, where we are able to identify it, we do engage, and then the practitioner has an opportunity to correct. Again, we would only really identify the errors if it is a consistent issue or error, or as we're doing the retrospective analysis, and then we're able to reach out. But as I indicated, we have implemented what we call, quantity frequency rules to be able to try and catch these upfront. But there are certain instances where we do see consistent and ongoing errors. And then we do have to engage to understand whether that is, a behavioral issue or, just a billing error. So I think I'll stop there. Thank you, Chair. I would perhaps just like to check if Joyful is covered by the feedback. Thanks.
Thank you, Chantal. Let's address her third comment around the allied health, and then we'll check if she's covered. If I can allow Mr. Ditswane to please come in and address the comment.
Thank you, Chair, and to everyone. I think we must just apologize on that one. Even in our scheme rules, we do not classify or categorize physiotherapy as allied. Physiotherapy is a standalone in our rules. So please accept our humble apology on that one, and then we'll rectify that when we share with you the slides. We'll make sure that it is rectified accordingly. Thank you.
Thank you for that. Joyful, are you comfortable that we move on? I see a thumbs up. Thank you for that. Shamila Daya, if you can unmute yourself and ask your question, please. Shamila, can you hear me? Okay, let's move on to Danny Matlow. We'll come back to Shamila. Danny, are you able to unmute?
Hi, can you hear me there, ma'am?
Yes, I can. Please ask your
All right.
question.
Okay, thanks. Mine is just a few comments and maybe one or two suggestions from my side. After Mr. Ditswane and Dr. Ziyanda spoke, I was left with the feeling that physiotherapy as a profession is being blamed for the statutory reserve challenges that GEMS is having at CMS, and that is quite unfortunate, and it also creates the impression that perhaps this spike in rejections and delayed authorizations as perhaps a cost containment strategy from your side to maybe get back to replenishing your reserves with the Council for Medical Schemes. And that I would say, if it is the case, it is very unfortunate and it's unfair and it is illegal. I hope I am not correct in that assertion there. And then the second comment that I want to make is on the rejection letters that that you guys sent us. Can you please try to provide sufficient reasoning for your rejections? And I put it this way because I think you will be fully aware of the fact that it is increasingly, or it's very difficult for us to get through to GEMS. So if you're just going to provide your reasoning as declined and no reasoning for declining and all, it gets really frustrating. And then on the issue of UMS, I'm going to suggest that you perhaps consider putting up a group training session, maybe run a series of those. I think that way you'll be able to reach out to a lot of us. The reason why I put it this way, I mean, to this day, I don't know how to use UMS. There's a gentleman, maybe you guys would be aware of on your side. His name is Kaiser Fori. Me and him had a couple of interactions, I think it was a year or two ago, and he was supposed to assist me with that. To this day, I still don't know how to use that function, and I struggle. So I'm going to suggest that you maybe consider that, consider creating training sessions in groups so that most of us that have common questions could be assisted on one single platform. And then the last comment that I just want to make is on your escalation process. I found it extremely disappointing. After our last meeting in April, I took a screenshot of the same escalation process that's being flighted in today's presentation. I'm not too sure who was presenting, I forgot, but that is not efficient. It's inefficient to say the least. Please work on it. And I think my parting shot maybe is just to say that let's understand that we are all in this for the interests of the patients. I do not want to get to work and see a GEMS patient and think to myself, ish, do I see them? Do I delay my treatment? Do I look away? What do I do? I think we need to understand that we are in this together for the benefit of the patient. I will leave it at that. Thank you.
Thanks for that, Danny. So I will allow Mr. Ditswane to address your first sentiments, and then I will then hand over to MCO to address the rest. Thank you.
Thank you, Chair, and thank you, Dr. Maklo, for your questions. I'll speak, I think, to two of them, and then I'll leave colleagues to come on and answer the others. Firstly, the conversation today is not necessarily a blame game or pointing fingers or accusing a physiotherapist in terms of the scheme's spike in utilization. this conversation is being done with other disciplines. And for your information and comfort, we started with the biggest driver of cost for medical schemes, which are hospital groups. We started that conversation with them late last year from September, where all of them, per group, we engaged them to show them that there is a high utilization that we are seeing of the benefits of the scheme. I think one of the colleagues also posted in the chat that with scheme growth, there's also aging membership profile, and with those chronic conditions also will be on the increase. So there has been a lot of work done to balance that in terms of what members are paying and our ability as the scheme also to pay for the services that they are requesting. So this meeting of today is not isolated to yourselves. We met with the occupational therapist on Monday. We'll be meeting with the social workers as well. So we've met with GPs. So it's an ongoing exercise that we are doing. But specific to yourselves, physiotherapists, and then the social workers and occupational therapists, there is this other discussion that we are currently having at the scheme around the mental health, which we are also going to invite SASPO, because they are the ones who we work very closely with to assist the scheme in terms of what we really want to see in the space of mental health. This speaks to some of the protocols, the scope of practice, and even the innovative ways of managing healthcare and the services that you are rendering. So there is a wider conversation that is currently taking place. So please be rest assured that this is not necessarily saying we are blaming everyone. In fact, the purpose of this webinar is also to establish a working relationship with yourselves, because we've picked up a lot of issues, especially from last year, in terms of the services, as you alluded in some of your comments, and some of the comments raised by colleagues around pre-authorizations, the delays, the requirements, the communication, all those issues. One of the decisions that we took was, you know what, let's just engage our healthcare providers. Let us all work together. Where we are wrong, please let us know, and we'll appreciate that, and we'll correct ourselves. And then we also expect the same with yourselves to also understand where we are coming from, because we all need to work together. I think all of us here, none of us in this meeting want to see GEMS not existing anymore. It is possible. The way things are going, if we allow them to continue the way they are, it's a matter of time that there won't be GEMS in the system. And I don't think all of us on this call will be pleased or happy about that. So the main important thing that I want everyone to take out of this session this afternoon is, can we work together? Can we resolve the issues? And can we move forward towards better ways of yourselves managing the GEMS members, and we, on the other hand, fulfilling that obligation of paying for the services that you are rendering? That partnership for me is very critical. Thank you, Chair. I hope, Nkate Maklo, I have answered you.
No, yes, you have there. But I just wanted to also add that as you are planning to engage the associations, please do bear in mind that some of us are independent of any association, and that not all the members are under SASP. So please just make provision when you do send out those invites to cater for independent practitioners as well.
Yes, through the chair, I hope you will also understand logistically it's going to be very difficult. However, we have avenues, like I mentioned, from the 1st of July. For some of those who are independent, who don't belong to any organization, even myself, I do make room to visit some of the rooms if I'm required to do so. You are more than welcome to engage directly with us as well, and we'll also do the same where possible. But it makes it easier when there is an organized structure, because then we know that we talk to 5 or 6 people and information can cascade further down to others. But your point is noted, and we'll look into it as well.
Thank you for that,
Thank you.
Mr. Dutsane. Dr. Ziyanda, if you can address the rest of the comments there in terms of the pre-auth processes.
May I hand over to Itu for that one, please?
Sure, Idu, over to you.
Thanks, Chair. I just want to make sure I understood. I think the first one was around UMS training. So we have been running UMS training from, I almost want to say, either late last year or early this year. For different providers, we run a session once a month. Our next session is on the 8th of July between 3 and 4:30. If you want to be added to the training, you just need to email that MCO PRS queries email address, and the team will then invite you to the actual training itself. We also do schedule enough time from a training perspective so providers can actually ask their question. And then the next one was around the escalation process. I think that I heard. I have noted your concerns relating to the escalation process and it being effective or rather not effective. I think in the chat there are a few people that have also said the same. We will look into it, but what we also encourage is once you have followed the full escalation process and you're not getting answers, please share that with the MCO PRS email address because that enables us to actually know what is working and what is not working because that comes directly to our team. But we'll definitely look at that escalation process because I know that last when I spoke to the team, they were within turnaround time from an escalation perspective, but I will check up on the team when I'm back in office. Thank you.
Thank you for that, Idu. Colleagues, if I can just allow me one question from the chat that I'll read out and then you can answer. It's around hospital updates. It says, why does James only approve ICD-10 codes that the hospital has updated? There are many cases where case managers do not look at reports of chest x-rays, which shows, for example, pneumonia. When we add the ICD-10 code for pneumonia, it is rejected just because the hospital has not updated that code. Physios are called to treat patients for pneumonia, then our auth is not approved. Would that be you, Idu, or Dr. Ziyanda?
Thanks. So from a coding structure perspective, we don't necessarily want a like for like, right? So if, for example, patient is admitted for respiratory, you coding, let's say pneumonia, and there's something else that says lower respiratory system, the team will accept it. I think where the challenge comes in, if the hospital has not updated that the patient has a pneumonia, we cannot go ahead and approve a pneumonia treatment because according to us, and the records that we have, the patient does not have a pneumonia. We rely on the hospital to update, and that's why sometimes it's a timing issue. It could be that there is an update that's maybe received on system our team has not actioned, but the team is in pre-auth is able to look at it. Or alternatively, the hospital is not updated at all. And then it becomes very difficult for us to make a decision. And that's why I encourage for UMS because you can see if the hospital dates have been updated and what has been updated for. It will make your life easier from that perspective. Sorry, that's a full answer, but yeah, that's the answer. Thanks.
Thanks for that, Idu. Next hand we have is Shannon Carrick. If you can unmute and please ask your question. Shannon? Okay, let's move to Jackie Feha. You can unmute and ask your question.
Hi, it's Francis speaking. So I'm wanting to find out. Sorry?
Yes, please go ahead.
Okay, cool. So I'm just like saying for certain conditions, so like I work in the joint arthroplasty space. So routine authorizations are supposed, you tell us they're given within 48 to 72 hours. But to be honest, most of our patients will be discharged within 24 to 48 hours. So now what do we do with that patient? Do we treat them? Do we not treat them? Do we hope for the best? Do we just leave them in bed until we get an authorization? Because to be honest, those are the claims that I have now that are not paid. And despite your authorization and your escalation process, I sit with claims over a year not paid. And I mean, we just engage with GEMS and it's just like, there's just no response. I've given, Karen will tell you, I've sent it to SASP. It's gone on the spreadsheet and just nothing happens. And it's just frustrating. So I don't know if we must wait 48 hours and just leave the patient and make them rack up escalation hospital charges because we can't treat them until we get an authorization, or treat and hope for the best. So that's one thing, is that I think in certain instances like joint arthroplasty, why not just when the patient is coming in for a knee replacement, just authorize 2 sessions of physio? It's not hard. Then we don't have to go through this claims process, phone, maybe get an authorization, escalate after 8 hours, escalate after 8 hours, wait for payment. It's the administrative burden of dealing with GEMS is exhausting. And it takes a small practice for a relatively small claim of maybe 2,000 Rand for a patient. The amount of admin that it takes for my secretaries to sort out those claims is hours. And I'm beginning to think it's not worth it. I have started telling patients to report you to the Council for Medical Schemes because I am exhausted. Okay, so that's one comment. Just send it through. If it's a routine thing, it's obvious physio is needed, get it done. The second thing is your patients are some of the most unhealthy patients. They have the most comorbidities, they are overweight, they don't exercise. And at some level, you're going to also have to do something to motivate to get that. I'm not saying Discovery is better, but at least there's a vitality screen and it incentivizes patients to exercise. But you guys don't do that. And so that your patients will sit in hospital for longer. I'm frustrated with GEMS. I'm exhausted by them. And I don't actually know what to do going forward because I'm starting to tell patients, I normally say to them, with GEMS, you never know what you're going to get. We can have 2 patients on the same day, same procedure. One will get an authorization, one will get paid, and the other we're going to sit and sickle for a year. And it's not fair that their patients they're your teachers, your policemen, your hospital administrators. They are lower socioeconomic. They do not have the funds to pay for it. And you just put an extra cost on the practice and on that patient. It is not fair. I'm done.
Thank you for your comments, Francis. Lefaronola, if you could please mute yourself. I will allow the MCO colleagues to provide a response.
Hi. I don't know if I'm visible or I'm audible. Francis, I think your concerns are heard and they are valid. And it's not the processes in place are not to cause the frustration that they are resulting in. And that is not the intention in the implementation or in the draft. The intention is to try and align patient care with some reasonability in terms of utilization. We do acknowledge that majority of clinicians are just trying to make sure that our members are taken care of, our members get the services that they need. So some of our interventions are not to cause frustration, but to try and manage in those situations where we encounter, some services that are not aligning with the clinical condition or with the information that we have at hand. The intention is never to frustrate and increase the burden and deter you from seeing or servicing GEMS members. And that is not the intention at all. We are working on improving as we speak now. We were sitting with the team to look at how do we make the processes more efficient while we do or administer the managed care process, but reduce the burden to the clinicians or the providers that are providing care. So yes, we know it's not perfect, and we know there's a lot that needs to still be done, and we are actively working on it. So it's not like in the background we're sitting and we are just happy that our providers are not happy. No, we are working on systems to make this more efficient for members as well as for our providers. There is no GEMS without providers, because we will just be sitting as a managed care organization and patients with no one to service those patients. So we do realize the importance of having healthcare providers. I'm a healthcare provider myself, and I do understand that. So just bear with us as we're fixing our systems. And I know, that means, patients and all of that, but we're not saying then don't see our members, still service our members while we improve our systems and still manage the other issues with regards to making sure that the appropriate services are being rendered. Thank you. I hope that helps. I know that doesn't cover most of your concerns, but let's know that, rest assured that in the background, we are working on improving the systems and being more efficient. Thanks.
Thank you so much, Dr. Zianda. We have about 25 minutes left of the Q&A, colleagues. So I'll ask that you just try and be concise in the asking of the questions so that we can cover as many people as possible. Jackie, your hand was up. I'm not sure if you're struggling to unmute. Please ask your question. Okay, we will then move to Lihlohonolo. Siane, please ask your question.
Good evening, good afternoon. Thank you for the presentation. I have one question. Does GEMS cover physio under psychiatry or not? Because I'm sitting here I actually have about 3 or 4 patients today that the doctors has referred to me who are admitted in a psych hospital who needs physio. And I told them that I'm attending a seminar, and by the time I'm done, I'll be able to tell them, the patients and the doctors, that I will or will no longer be seeing their patients, because I have a lot of authorization that I've requested with the motivational letters and everything. I have worked so hard. All I get is rejections after rejections after rejections. And I wake up in the morning, I try and go work, give my best, your patients would appreciate. And I try and explain to them before I see them that this is the procedure, this is GEMS, this is what GEMS requires, and this is what I'm going to do. But I'm not sure if I will be paid. So, and the patients who are admitted in psych, they present with pains. You see, in the prescriptions, you'll find that every patient gets all these analgesics. And basically it's because they present with somatic pains that are related to depression and you name it. So I'm sitting with this situation here and now because I want to be told that we are not going to pay physio. You can just give your services for free, or I just need an answer to that one. And you get 5 patients, we send all those things, the required documents, and only one might be accepted for one day. Then you try get the other days, it's the same problem of getting rejections. And these patients who comes there, they are depressed. Some of them is financial problems as well. And then they end up, after you treated them, they're better. They are not struggling with having to pay you as a service provider, because we fight, we send, we resend and resend. Sometimes you'll be lucky, sometimes. And I just want an honest answer. Do you pay physio under psych or you don't? Thank you.
Thank you for your question, Lihlohonolo. We appreciate it. MCO colleagues, please park that question. I'll take Boitumelo and then you can answer both questions. Boitumelo, please unmute yourself. Boitumelo. Okay, let's move to Karen Engelbrecht.
Good afternoon. Thank you so much for hosting this. I think if I'm trying to understand the problem from Gem's side, I can see that you guys have a problem, and we all agree that we don't want Gems to bite the dust. But I think you are trying to fix the problem by looking at physios, which is our claims, although you have these huge numbers, is really a drop in the bucket. The biggest expense that any business have is salaries. And if I look at all the processes, I've been attending the GEM Summit for last year, this year. I've tried really be part of this. And we always get exactly the same message. It's always the same escalation process that doesn't work. It's always the same email addresses. It's always the same stuff that we have to jump in the loops, and we have to employ more and more people to help us with us because we can't cope. And obviously you guys can't cope with the amount of work that you have to do on that side. So the system is broken. I really don't think that physios are, I do agree that there are people that might be doing illegal stuff. I'm not saying that's not going to happen, but I don't think that you're looking in the right place to save gems. My next comment is on Code 501. If you look at any research, then you'll know that 501 is probably the most important thing that we can do for patients these days. Our coding system is completely outdated. If you do any exercise or rehabilitation with a patient and it takes you 20 minutes, you can only charge $130 for that. If it takes you 10 minutes more, you can charge 300 Rand for that. It doesn't work like that because patients can only do as much as they can do. So we need a different way of billing a patient for the time that we spend with them. And to say that we're charging 501 too much is basically Jem saying that we're not supposed to be doing rehabilitation, although that is the most important thing that we can do for our patients. Then my last point is just that patients are getting more and more clued up with what their benefits are. And that's partly because GEMS has these drives where they tell patients, you can go for physio, you can do this, you can do that. So if you are hoping to win more members by doing this, that's great. But you must also bear in mind that patients now know that they can go for physio. And like Francis has rightly said, the majority of these patients, and you showed it in your presentation as well, is the retired teacher or the retired policeman that now realize, oh my goodness, I can actually do something about my sore back or my sore knee or whatever. And for us to slap an ultrasound machine on him and say, do 5 straight leg raises, off you go, is not going to do anything to his general health. We have to rehabilitate this guy. We have to spend time with him. We have to try and get him better. And that's going to be 501. So I think you're looking in the wrong place to try and save the medical aid. I also think that very often I see patients get an authorization for an operation within seconds. The orthopedic surgeon will say, oh, you've got carpal tunnel. You need an operation. And the patient hasn't had one session of physio. I see him post-operatively, and it's not carpal tunnel, it is cervical preferred pain. So nothing has been done conservatively to try and save this patient from having an operation. But an authorization will be given within seconds to have surgery and hospital stay and possible complications. I think that's all. Thank you.
Thank you for your comments, colleagues. Chantal, if I can start with you in terms of commenting on the code 501, and then I'll hand over to MCO colleagues.
Thank you, Nonto. I think We have heard and seen on the chat the comments around the 501 and perhaps what we can do. We do have engagements with the respective societies and associations from a coding perspective. Perhaps it's something that we also raise there and see how we can deal and address with it. And I think in sharing the feedback from a fraud, waste, and abuse perspective, the intention was to share some of the anomalies that we see and the outcomes of the investigations. It was not intended to say that 501 is the incorrect code being billed, and we do see it as the highest tariff code paid, funded, etc., which we do fund it because we do realize the importance and the role, of the physiotherapist. But I do see that it has created some concern. But again, I just wanted to reiterate that the information we were sharing and where we speak to the concerns around 501, it's where, further analysis has been done and we have found either overuse or abuse, etc. But I think the concerns and the points are noted, and perhaps it's something we can engage the societies and associations on. Thank you.
Thanks for that, Chantal. Itu, please go ahead.
Thanks, Tonto. So I think the first question was around mental health for physiotherapy. Toki wanted a yes or no answer. So I think it was actually covered in our presentation, but the yes or no answer would be we do not fund. There are no benefits available in a mental health unless patient was, for example, admitted a few days prior for either a surgical admission or a medical admission. And in that instances, the team would then look at it based on the clinical information that they receive. But for your example, for your dorsalgia, cervicalgia, muscle spasms, your group therapy for relaxation, massaging, stress relief is not covered in your mental health facility. And then the next question or statement was just around the system that's broken. And I think the one thing that we have been, I was hoping we were clear about today is we want to engage with you as providers. We know the providers that do engage with us, and I think someone mentioned earlier that those that are, for example, within your SASP, we engage with SASP, but we want to hear from you, and the only way we will hear from you is through such communication, and we do want examples of those instances. So the main reason why we really wanted to talk to you as providers was not necessarily to bring the escalation matrix, but was to say there was an issue that was noted between Jan and March, and there is an extra process that is now available for those providers whose authorizations have been rejected incorrectly, for those to actually be reviewed. And if anything is taken really from this meeting, that's what I would love for everyone to understand. If there's an authorization that was rejected, for example, no number of visits were not authorized in a particular period, but you did have an auth. I think it's important for us to help you with those. We understand these are small businesses, and that's why we are opening that extra revenue, extra avenue for us to be able to look at those particular cases. Obviously, these cases are coming in fast and furious. So we have a team that's working on these cases. We are trying to get them out as quick as possible. I've been getting them from a lot of providers for that period. I know I mentioned Jan to April, but if you have from 2025 where you have noted this issue, please share it with us. Let us have a look. If you have a consolidated spreadsheet where we can look at those cases, it would really be great. I think there was also someone earlier that mentioned around the arthroplasty authorization and how we should just load. I guess if we can receive that information up front, it's always the treating physios details that are missing from the hospital auth. If everything came to us in one go, I think the team would definitely be happy to look at that. I will discuss it internally with the team, but then I think from an information that we receive perspective would also need to be updated. As a team, we are constantly trying to improve services. We know we don't always get it right, but we are willing to engage. And we do engage regularly with those that are available and that avail themselves to speak to us and give us what they are seeing from their practice perspective. Thanks, Nonto.
Thanks, Edu. Kevin, please go ahead.
Thank you. Good evening. I just want to stress, if it hasn't already been mentioned, that UMS system is completely user-friendly. All you need is a simple form where people can fill in the information you need. You've got all these drop boxes which hide the information you require. It is the most frustrating, useless piece of software I have ever seen. It looks like it was co-opted from somewhere else and you've just slapped it on your system and now we're having to use this. So I really, really encourage you to change that. Just go to Google Forms, put something on your website, we'll fill it in and submit it. It'll make our lives so much easier. You can't believe how frustrating that thing is. Another thing I want to raise, your claims department and your authorizations department don't seem to be speaking to each other. I'm struggling to get authorization, and then I keep on getting these remittance forms from your claims department requesting that I get authorization, which you guys are blocking. It is unbelievable. So I'd really encourage you to change this. There was a third thing that I wanted to mention. Oh, with regards, if we are supposed to use this UMS system, can you please create a PDF document where you've got screenshots and show people what they need to click on? All these webinars are hours long. They don't get to the point. Just create a PDF document that we can see what we have to do if we have to use this UMS system. So I would really encourage you to do this. It'll save you a lot of time. You're doing all this education, which probably is not necessary. Just create a PDF that we can click on things that is user-friendly. Thank you very much.
Thanks for that, Kevin. Colleagues, we are about 8 minutes until the end of our session. With your permission, I'd like to request that we push until 6:15. We do have a number of hands. I want us to try and cover as many hands as possible. Please, I'm asking that you try and be brief in your questions so that we allow everybody to ask their questions. So I will move to Desmond. Apologies. Desmond, if you can ask your questions and then the colleagues can answer both colleagues.
Thank you. Mine is with regards to the back and neck program. As GEMS, you are accepting the current back and neck program. It is not just unlawful, but it is illegal. It contravenes so many rules, in particular, Rule 7, Rule 8.4, Rule 9, and Rule 22. Yet you continue with it. I submit.
Desmond, I'm going to allow our colleagues to answer to the two questions that were raised from the two colleagues. I'll start with MCO before I allow our other colleagues to answer to Desmond's point.
Thanks, Nondo. So I've noted the concerns relating to the UMS system. I we'll pass the sentiments back to our technical team. But just to mention that there is a user guide for external users that has been shared with providers on various times, and we also do share it in the training as well. It is part of the attachment, including the access form, the guide, and how to actually sort out the pop-ups. But we are happy to reshare. I think if we are sharing a pack with this webinar, I think we are happy to reshare that as well.
Thank you very much. Billy, if I can ask you to please respond to Desmond.
Thank you, Chair. So Desmond, I will really like to take you on your submission. I'll just say two things. One, the rules of a medical scheme, as well as the benefits contained therein, are approved by the Council of Medical Scheme. And I would really appreciate on the second point, if you could share with me, we'll provide our email address at the end. If you could share with me all the concerns that you have, because I heard you referring to rules by numbers. I don't know which rules are those, but I'll appreciate if you could share that with us so that we can have a look at that and then assist by giving you also a formal response to those things. Thanks, Chair.
Thank you for that. Sakile, please ask your question. Sakile, are you there?
Hi, can you hear me?
Yes, I can.
Oh, okay. Well, my question basically is regards to the benefit guidelines. I was more interested in asking that how often is GEMS looking at the research in terms of the funding criteria? I was going to make an example of now you were talking about the patient in terms of the laparoscopic procedure, that it's only going to be given for physio if there is complications. But I'm sure out there is research which says either, where a patient might need an intervention of the physiotherapist to be seen in hospital without necessarily having complications for the treatment to take place. So I just wanted to know how often you guys look at the recent researches in terms of the guidelines when it comes to treatment. And secondly, it was more or less of asking if is there any communication platform or individuals that we can contact as service providers in terms of giving you information which might render good for us so that we can in future have these benefit guidelines to be reviewed in terms of what can a physiotherapist do in terms of treating the patients in hospital and as well as the outpatient benefits.
Sakile, can I have Tabo ask his question, please?
Hi, can you hear me?
Yes, I can.
Yes. I just have a quick one. I just wanted to know what can be done to improve the streamlining of length of stay updates on the side of GEMS, because hospital case managers do send you length of stay updates daily, but you would find that the patient would be sitting in ICU for almost a month, and the authorization approved for physio would be like 1 or 2 days. And you would follow up with the hospital case manager, and they would even show you proof that daily they've been sending length of stay updates to GEMS. But when you try and follow up with the escalation process of finding whether or not your authorization can be increased its length of stay, nothing gets sent back, or you get sent the same thing over and over. So, with many cases that we've dealt with in the hospital, it shows that there's a challenge on the side of GEMS with regards to streamlining the length of stay updates with the hospital. So, I just want to know on your side, what can you do, or what can you improve on, or what are you working on to improve streamlining of length of stay?
Thabo, I will first allow Mr. Dutwane to address Sakhile's question, and then I'll hand over to our MCO colleagues for Thabo's question.
Thank you, Nantubeko. So, Dr. Sakhile, maybe I'm going to give a high-level overview of some of the processes that we have from the scheme side in terms of the benefit design and the products that we have. Then I will also allow maybe my colleagues from the scheme to speak to the clinical guidelines and protocols that are in place. So on the scheme side, we have an annual exercise where the individuals and societies can submit to the scheme any ideas or proposals that they have that they want the scheme to look in terms of the benefits. So that is a competency that is at the scheme. Also other things like tariffs that are like the coding structure. We normally work with SASP and other related societies where if there is any change that they want the scheme to take note of, we then apply. We do also work through SAMA as well, where there are any changes in the coding structures. So that is that one. And this exercise is done annually. At the scheme, we normally send out a request as early as February. Then we start working through the year so that in the next benefit year, if things are approved, then that communication is then sent out and the necessary changes are implemented. I know that SASP has in the past been sending to the scheme, but there has been a gap where there was a transition from one division to a division, another new division that was now managing that process. And I must admit, there has been, I would say, poor communication on to the feedback that needed to go out on some of the items that were submitted. And as I indicated earlier, I think to Karen, we are currently with some of my colleagues looking at all the past submissions that have perhaps not been responded to. And I'm hoping that as early as next week, we should be able to respond to SASP on some of those submissions that were made. And also if there is an opportunity to review, because I think there was one particular case, I think Karen might recall, where the response that was given was also raising a lot of questions that SASP needed clarity on. So I am currently looking into those, and as I indicated, will give some feedback. Now, coming to the managed care protocols and clinical guidelines, I think colleagues from the from the managed care organization do also have what they call a health policy unit, but I'll allow them to speak into what goes in there and then how through them you can channel some of those. But there is always an opportunity to review because nothing stays the same, especially in clinical practice. I'm not sure, maybe Kimeling or Dr. Zianda can assist you on that one. Thank you.
Dr. Zianda, please go ahead.
Not a lot to add from Mr. Tiswane's statement, just to say as a managed care organization, we do have clinical governance structures that look at new research, emerging, clinical findings, and any updated, especially in the managed care context, that will either one, improved member care, or one, reduce the scheme risk, so that we are able to then have the most up-to-date literature, up-to-date evidence-based clinical care from both our health profession, health strategy unit, as well as our health professional service provider unit. So both those units are constantly, and this is not an annual thing, but on a constant basis, looking at what new research is there, what is it that we can implement that can improve our member care as well as the scheme's service offering, whether be it prevention, be it management of acute or chronic diseases, as well as reducing the need for higher costs. I think someone said earlier on, physios are there for multiple reasons, but one of them could be to improve on the cost that we could otherwise incur, let's say, where a patient now need to have surgical interventions, which means admission and all of that. So we do look at those so that we then optimize our offering for the scheme. Thanks.
Okay, Dr. Ziyanda. Sandla Sihle, please ask your question.
Oh, there we go. Hi, good evening. Thank you for the presentation.
We can hear you.
Oh, great. Thank you for the presentation. I just have more like questions and comments, two things. I know SASP keeps coming up as if SASP has been engaged about the issues that we seem to be you sort of seeking clarity on today. Am I correct? That the South African Society of Physiotherapy, you have engaged them?
Yeah, if I may, if I may, apologies. So, colleagues, if there are any other formations within physiotherapy, please reach out to us and share those details, because if you don't share that, we won't know. So we'll be dependent on you to send us your details so that we can engage with you. I have been with GEMS for the last 6 years, and when it comes to physiotherapy, I've only known about SASP. That's what I came to find at GEMS. So if there are any other formations, please feel free, because we don't engage just one, we engage all. Anyone who has an interest and is representing, even if it's only 50 or 60 or 80, given the opportunity, we will have those direct engagements. I hope I've answered you, ma'am.
Just as a follow-up question to that, I just wanted to say some physios, someone did mention, are not affiliated to SASP or any other organization that is within a physiotherapy. Some people are literally independent. So it would be great that whatever information that is shared with the bigger bodies, say SASP or whatever other bodies there are, that the individual members also get it, whoever is a GEMS service provider. We also need to get that information, because maybe decisions are being made on our behalf and we are not aware of those decisions. So I'd just like to pass that. Number two, what I would also like to find out, as much as we are experiencing the issues of all the red tape of authorizations, are your members aware of it, that this is what is actually happening at GEMS? That's A. Number two, are the hospitals and the doctors aware of it? And the reason why I ask is because if the doctors and the hospitals are not aware of it, we're going to keep getting these referrals. There's going to be an expectation that we keep delivering a service every day, because typically, say, an ICU patient is going to be seen every day in any case. Typically, I'm talking now at in-hospital level, typically those patients are seen on a daily basis. So it would be better if you could also let the hospitals know that, look, currently this is what we are doing. Authorization doesn't necessarily get granted on the day that the physiotherapist requested. Sometimes it's an 8-hour process. Sometimes it's a 48-hour process, so that even when the doctor makes a referral, they are aware that my patient might not be seen today. My patient will only be seen once that authorization has come through, so that also the family members and the members are aware that my family member who is in ICU might not necessarily be seen by the physiotherapist today, tomorrow, even the next day, or even in the next 5 days. So in the interim, let me make a contingency plan that should that authorization not be paid for, we must be prepared for a bill from the healthcare provider. Thank you.
Thank you for that, Sandla Sihle. If I can take another comment before then the final answer. Peto, please unmute yourself.
Good evening, colleagues. Firstly, I would like to address and make a comment to Chantal about the Z50.1 code. She mentioned that it is the mostly used code. Yes, it is mostly used because it's the most approved code by the scheme. For example, today I received an authorization from GEMS where J45 was left blank and then Z50 was approved. So it's not a problem from the physio side, it is your system. So I think maybe you should look at that. And again, for me, I've been in practice for quite some time, and I have noticed the unnecessary burden, administrative burden that GEMS is posting on physios, and it's exhausting. For example, with mental health, at first, a referral letter was requested, and then GEMS paid. Then it stopped paying, requested a referral letter from the doctor, as well as a motivational letter. That was granted from the doctor managed to give us. Then we claimed we got paid. Then GEMS stopped paying. Now, recently, we experiencing the same thing with post-cesarean section, where you request an auth on UMS, and then it gets declined. You send an email, follow all the escalation processes just to get a one-day authorization. I feel that is unnecessary, especially for those that have big practices. Another thing, it's with the UMS, who someone made a comment that system, no, guys, because we recently, we used to request an auth. You would give us 10 days. Recently, without communication, one day was paid. We called claims department and they're like, you need to increase number of units. We're like, what is that? No one answered. We looked at the same system, the UMS. We don't have a tab where you can increase those number of units, right? Then we have to again escalate. Then we do not get paid in the next run. Therefore, you send a claim, you do not get paid within 30 days. And according to Section 59.2 of the Medical Scheme Act, medical scheme must settle any amount owing for a rendered health service within 30 days of the claim received. Recently, we're not getting that. You send claims, you get a remittance, you go line by line, nothing that you send in the last 30 days. It's not on the remittance. So I think on your side, the administration burden that is posted on physios is exhausting. We want to work. We had to provide services to your clients, and you guys know that your clients are low middle class populations, where if I give them my bill, how will they pay it? You guys know your population. So I think from your side, you need to do a bit better. Thank you very much.
Thank you, Peto. Unfortunately, due to time, colleagues, this will be the last question that we can take. If I can first ask Chantal if you can provide a response before handing over to the MCO colleagues.
Thank you, Nonto. And to the question around the ICD-10 code, I think, again, I'm not in my presentation saying that there's anything wrong with the billing of the ICD-10 code. It was just to share the claims experience, and where we do have any concerns, we raise it with the individual providers. So if there is something that we need to look at between us and the managed care, as part of the authorization, we certainly will do that. And I think we note the comment. Thank you.
Thank you, Chantal. MCO colleagues.
Sorry about that. I'm struggling to switch on my camera. I was busy answering the questions over here. So I think the question, Nonto, if you can assist me, it related to the pre-auth?
Yes, Dr. Zianda, it was related to pre-auth.
Okay. Sorry, I didn't get it. I was trying to respond to the questions
Dr.
online.
Do you want to repeat your question?
There's lots of questions
No,
on my
that's
note.
fine. Sadlesihle, do you want to repeat your question?
Sadlesihle still, maybe he's still muted.
Maybe she's.
I can't see the name to see if they're muted or not.
Okay, she may have dropped on the line. No, that's fine. I think she may have dropped the line.
Apologies about
I think
that.
in the interest of time, then colleagues, can I then move to the final? Can I then move to the final item on the agenda, which is then the closure by our senior manager, Mr. Ditswane? Over.
Thank you, Chair, and thanks everyone. I hope that you have somehow understood the position of the scheme this afternoon, which, as I said in my opening remarks, was purely to establish a working relationship with all our healthcare providers. We are well aware of the issues and the challenges that you are facing. And we decided as the scheme that in order to solve the issues and get to a solution, let's not do it alone. Let's do it together with all our key stakeholders, being yourselves. Hence, we have this session this afternoon. And I can assure you that this session has been recorded. We will also be sharing the copy of this as well with yourselves. And I can comfortably say that we will also schedule another session, hopefully before the end of October in this year, so that we can do more of a check-in to see what progress has been made since we have met. So the information that you have provided to us in this session is very valuable. It has opened our eyes to some of the problems that for most of you, as you may be aware, GEMS is operating on an outsourced model, and we have service providers that are rendering those services. We are sitting at head office, so we can only get that informed feedback through such engagements with yourselves. Hence, we have in the room both MedScheme and Metropolitan Health. So the three of us, we have taken all that information. We are going to sit and review all the concerns and address everything. And I'm hoping that by the time we meet before end of October, we will be coming to report back to yourselves and to see the progress that we have made. That one, be rest assured, you can hold me accountable to that one, that either nothing has improved, but I can assure you we are really going to work towards ensuring that all your concerns have been addressed. Where we need to change in terms of some of our processes, we will also do so. And then on the question of the representatives, please, if you are part of any formation representing physiotherapy outside of SASP, please feel free to engage us with your contact details. An email will be shared, especially that one that says summits on your screens, summits at GEMS. Anything that is specific to GEMS outside of what is being flighted there, please feel free to engage us through that. And I must say that that email address is not always attended to, but as an interim solution, where we also at the scheme want to have visibility of the issues, please, you can use it, but we have a very limited time frame. Chair, I can't remember whether 7 days for that one specifically. Other ones are routine email addresses that are in use, but we have included the summit so that at the scheme we can have a view. Now, another issue that I mentioned earlier is that our provider liaison officers will be coming from 1st of July to be engaging the practices, and all those issues around communications will also be delivered to yourselves. And I must say that one of the most important things that we always struggle with is the correct contact details that we have on record. For some colleagues, we don't have. And even when we send communications, they don't receive. So I'm also going to appeal that please make sure that your contact details are up to date. Lastly, we have a provider app portal at GEMS, and I will encourage that if your practice is not yet registered, please feel free. It's a very seamless registration process. The recording of this session will be posted there so that you can, at your own leisure, go through the issues. And all the correspondence, all the communications are all there. And all other educational and very important information is kept there. And before the end of this year, GEMS will be rolling out a upskilling program for our healthcare providers to assist with very important information in terms of running your practice, like coding and other related information like fraud, waste, abuse, and error. So we have packaged material that will be very useful, and most of it will be CPD accredited, and it will be at no cost. It will be for free. GEMS will be covering the cost to assist our healthcare practitioners with the necessary upskilling. So colleagues, this session of this evening will also be shared with you. All the questions that have been submitted, we have tracked them, and then we will be responding to all of them in writing. So like a Q&A document will be shared within the next 2 weeks with all attendees of this meeting. And then we are hoping that through that, we will close the gaps. I think the biggest issue is our processes around the managed care. So as indicated earlier, that's an area that we're really going to focus on. And I'm hoping and convinced that when we meet before end of October, you will be telling us how things have improved. And in between, if things are not improving, it doesn't mean that you have to wait for October. Please feel free to engage us and say, GEMS, it is not working. We really will appreciate that, because we are doing all this in the interest of making sure that you run your practices efficiently and GEMS members are serviced accordingly. That's all that we want to do. If services have been rendered in line with the scheme rules, benefits should be paid, claims should be paid within a reasonable time. That's what GEMS is all about, and we really want to work with you. And I'm hoping that all our pleas to you this evening did not fall on deaf ears, and the same with yours, as I've given that assurance. So I'm looking forward. I'm hoping that myself will come to 1 or 2 or 3 practices when time allows, anywhere throughout the country. And as I said, PLOs will be coming from the 1st of July to be engaging as well. So we have a QR code. If you could please give us feedback, even if it is negative, it helps us to improve and to do better. But I can say overall, having this session this evening was a very useful one, and I'm hoping that it was of benefit to you to at least have people that you can talk to, the scheme directly, and address the issues. And for those who are in the Eastern Cape and Free State, we are looking forward to seeing you when we come for the healthcare summits. It's a full day CPD accredited event. You are also welcome to come with your practice managers or by yourselves and spend the day with us and see us in person and see how best we can also assist you further. With that being said, Chair, I think I want to appreciate everyone, and I think we must clap hands for having such a very fruitful meeting, and the issues have been raised and we'll be attending to them as promised. And looking forward to seeing you all, Free State and Eastern Cape, and hopefully on this webinar again before end of October this year. Thank you, Chair.
Thank you so much for that, Mr. Ritwane. And thank you so much to the colleagues who have managed to stay with us until the very end. We really do appreciate your time. We know that time is not to be wasted, so we appreciate your efforts in engaging with us. I wish you all a wonderful evening. The session is now closed. Thank you.